Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami. Welcome to our Monday afternoon Instagram chat. Today's topic is frozen embryo transfers, options, and why we do what we do. For those of you not familiar, frozen embryo transfers have to do with how we coordinate the cycle when we have embryos cryopreserved. And the reasons for embryos being cryopreserved are either from they were leftover embryos from a previous cycle in pregnancy, or as most of our patients nowadays elect for what's called pre-implantation genetic testing, where we've actually biopsied the placental cells prior to freezing the embryos so that we can do genetic testing for aneuploidy to make sure the embryos are nice and healthy. These embryos are cryopreserved, and now we have to decide how and when to put these embryos back into your uterus. So the concept is that when an embryo is frozen, it's at a certain point of development. And in a menstrual cycle, normally, the endometrial lining is capable of accepting an embryo only for about a 24-hour window. And this is known as the window of implantation. And so normally what happens in a regular cycle, if you get pregnant on your own, the egg is fertilized and is transported down through the tube as an embryo back to the uterus, and it then goes to implant. And there's this little window of 24 hours where the biological events on a molecular level in the lining of the uterus are in concert with what's happening with the embryo, so that the communication between the two is correct, and the embryo can now stick. Some people will describe this as kind of the Velcro of the uterus is right and the embryo is right, so they're able to stick together. So the issue is when we're planning a frozen cycle, the concern is how do we know we're in the right spot? How do we know when the embryo is ready to go in? The embryo is what it is, and the embryos very often with IVF are most commonly frozen as a blastocyst stage of development. But blastocysts can be frozen either on day 5, 6, or 7 of the cycle. Most good quality embryos are frozen either on day 5 or 6. Sometimes embryos slow down a little bit in a dish, so they're not ready to be cryopreserved until day 6 or even day 7. And the issue is, how do we time these? So when an embryo is frozen, it's frozen at the blastocyst stage. And whether it's frozen on day 5, 6, or 7, we call it a day 5 blastocyst embryo, because that's the point where it should be at that point. So even embryos that are slow growing, what this allows us to do is kind of to resync them in the uterus at the correct time. So we have embryos that are 5 days out from when the eggs were retrieved, which is 7 days from when the HCG trigger of ovulation takes place. So it's 5 days post-ovulation that an embryo is ready to go back in. It's related to the endometrial lining being developed appropriately, and that's a reflection of estrogen, and then a conversion of the glandular elements that line the endometrium to be able to produce secretions and a secretory lining that allows for the embryo to be nurtured, implant, and develop. So how do we figure this out? Now, if ovulation occurs naturally in a normal cycle and a couple trying to get pregnant, those changes occur on their own most of the time, and things are synced out pretty much okay, except in patients who don't ovulate properly and need some hormonal support. But once ovulation occurs, the ovary makes progesterone, the egg gets fertilized, the embryo gets transported to the uterus, and it arrives in the right spot at the right time more often than not, and the embryo can stick. So on a frozen cycle, we now have this embryo in the freezer, and the question is, when do we thaw it and how do we get the uterus to be in the right spot? So there are a couple different ways to do it. The most common thing that we do is what's known as a programmed frozen embryo transfer cycle. And it's called that because what we do is we turn off the normal menstrual cycle by using a medication called Lupron, which if taken daily, starting about a week before a period comes down, or if you're using a birth control pill beginning on the 14th of 21 days of active pills, at the end of that period of time, the Lupron is downregulated the pituitary gland. And as a result of that, there isn't any endogenous hormonal stimulation to the ovary. The ovary is quiescent, you get a period, and the lining is kind of at the starting gate. It's in check at the beginning of the cycle. We now have to have two things occur. The first thing is to get that lining to thicken up so that it's okay. And a normal endometrial lining in the middle of the cycle should be at least 7, no more than 16, with the sweet spot being 8 to 12 millimeters in thickness. And the growth of the lining in the first half of a menstrual cycle is related normally to the body's production of estrogen, specifically estrogen estradiol. Basically, estradiol is a type of estrogen. And so we can give you that medication. So we turn off the ovary, and then we give you estrogen, usually in the form of an estrogen patch. So this allows you to absorb it transdermally through the skin, and the effect is to thicken up the lining of the uterus over a 2-week period of time. Now, we usually change the number of patches that you're taking a couple times during that first 14 days so that we're simulating the normal estrogen levels that the body would make if you were 18 years old and ovulating totally normally. So we allow the uterus lining to thicken up. In the middle of the cycle on the 13th day, we do a blood test to make sure you're absorbing the estrogen we're giving you, and we look by ultrasound to make sure that the lining is adequately developed. If the lining is adequate at that point, then we can start progesterone, which usually occurs once ovulation takes place. If the lining is not developed, the good thing here is we can hold off starting the progesterone and kind of drag out the first part of the cycle by 3 or 7 or even 14 days if we need to allow the uterus to thicken up. So one of the big advantages of a programmed cycle is giving us a little more flexibility on the timing as well as how much time is involved with thickening the lining. But the key in determining when to thaw the embryo is that once the lining is adequate, we have to then add progesterone. Progesterone converts this, what's called a proliferative lining, the growing part of the lining, into a secretory lining so it secretes proteins that nurture the embryo and allow implantation. And it's the dose and the total exposure of the progesterone that determines when that embryo needs to be put back in. We usually transfer on the 6th day of progesterone, correlates to the 20th day of the cycle. So that in most patients that we put on a programmed frozen embryo transfer cycle, by turning off your own production of hormones and then giving you estrogen and then providing progesterone, we know when to time the thaw of the embryo to be in that 24-hour window of implantation. Estrogen is usually given with patches that you absorb through the skin. Alternatively, it can be used orally or sometimes in combination with vaginal estrogen. And in rare events, we would even consider using intramuscular estrogen. We save that for when all the non-injectable methods just don't work. So it's pretty rare to need to use injectable estrogen, but sometimes we have to go that route. Progesterone, there are basically 2 different approaches to progesterone. The simplest approach is to use intramuscular progesterone, and that's done once a day. And the benefits of intramuscular progesterone is we get sort of predictable blood levels. It has the desired effect that we need it to on the lining in most patients. It's less expensive than the other alternatives of progesterone, but it's literally and figuratively a pain in the ass because it's an injection intramuscular in the butt. And as progesterone support of the pregnancy has to be maintained through about the 12th week of pregnancy. So if you get pregnant, you're going to be on this stuff for about 10 weeks, and some patients just have a hard time taking injections that long. The alternative is to use a combination of oral and vaginal progesterone. The oral progesterone is called prometrium, and the vaginal progesterone is a gel called crenone. And the advantage of the oral vaginal is that it's not injectable. The disadvantages of the oral-vaginal combination are some people are very sensitive to oral progesterone and get moody and irritable. And the vaginal progesterone is in a gel, it's an emulsified gel, and some women just can't stand walking around with this gooey, white, clumpy stuff hanging out in the vagina, basically. So some people prefer one, some people prefer the other. The cost is significantly different. You can end up spending up to $3,000 more over 10 weeks for the oral vaginal progesterone over the intramuscular progesterone. So the intramuscular is simpler, less expensive. Blood levels give us a better correlation with what we're giving you, but success rate wise they work the same. So we're happy to go with either oral vaginal combination or intramuscular. It's just a matter of which set of benefits and evils you prefer. The benefits are they both work the same. The disadvantages, progesterone is intramuscular injections, the oral vaginal, more expensive, and sometimes you've got this gooey discharge that you may or may not tolerate. Once you put the embryo back in, 9 days later we do a pregnancy test. If it's positive, we continue the hormonal support until we see evidence of what's called the ovarian placental shift in hormone productions. With a normal pregnancy, the ovary makes the hormones to support the pregnancy initially, and then once the placenta starts making its own hormone, you don't need the ovaries. At the end of the first trimester, if you remove the ovaries from somebody who is pregnant, most people would do just fine. They would not miscarry. If you remove them prior to that time, you'd be removing the factory that's producing the hormone, and you would miscarry from taking the hormones away. So when we give you estrogen and progesterone, it's the same thing. We're your ovary. You need to take the medication until we see evidence that the placenta is producing its own, and we monitor this by doing blood tests for estrogen and progesterone every week or two through the first trimester. And once we start seeing evidence that the placenta is making its own hormone, we start decreasing the estrogen, then we start decreasing the progesterone, and by 12 weeks, usually we have you off of all the stuff, and then you're just like every other pregnant patient on autopilot with the baby and the placenta producing its own hormone to support the pregnancy. You can also put embryos back on a non-programmed cycle. You can put them back on a natural cycle, or what's better called a modified natural cycle. That has some advantages and disadvantages. There's less medication costs usually. It makes it a little harder to figure out exactly when to transfer the embryos. And in 15% of cases, cycles might get canceled because we can't figure it out, or ovulation occurs too soon, and we're not quite sure exactly what day to start things. But on a natural cycle, you need a lot more visits in the middle of the cycle to try and figure out when ideally you're producing a dominant follicle, you're making a lining, and then we trigger off ovulation. One of the big advantages of a programmed cycle is we know you're getting pregnant with the embryo we're putting in. That's an embryo that's usually been tested, and we know it's genetically acceptable. If you're using a natural cycle, you're going to usually ovulate on that cycle, and obviously we prefer you not to get pregnant from that cycle, even though you're having trouble getting pregnant in the first place, because we don't know what embryo it is. We don't know if it's been tested. Obviously it hasn't been. So if you can use a natural cycle, you need to use some contraception to prevent pregnancy in the natural cycle. The other big disadvantage of a natural cycle is we don't know what day of the week it's going to be. It's hard to time things. It's hard to make plans. With a programmed cycle, you know pretty much a month ahead. Most likely your transfer is going to fall on a given day. With a fresh cycle, it can fall any day during the week. That also affects which physician is doing the procedure, and since most patients prefer the doctor that they have had the most contact with, who's been managing their care, to do the transfer, it's easy for us to coordinate that when we're using a program cycle. But in all honesty, with a natural cycle, we can't plan anything till 2 days before, and as a result of that, who's ever on call on that day is going to do the transfer. And you can't be upset at us if you want Dr. Jacobs to do your transfer and Dr. Jacobs isn't here, or Dr. Ackerman to do your transfer and Dr. Ackerman isn't here, because we can't plan it that quickly ahead of time. So program cycle is our preferred way to go for those various reasons. We usually don't like planning a frozen embryo transfer cycle or any transfer cycle of cryopreserved embryos until we have the results of genetics. We don't want people to be taking medications to only have them canceled when we find out we don't have, in a rare case, where we don't have any normal embryos to put back in. So we usually wait for the genetic results to come back. In some patients, we can do a shortened version where we can transfer in the immediate next cycle by using hormone replacement with, instead of Lupron to downregulate the pituitary ahead of time, we can use the antagonist medication to prevent ovulation and still get the embryos transferred the next month. So that's another variation on the theme that's also possible for us. So the multiple ways you can transfer embryos, the most common way is on a programmed frozen embryo transfer cycle where we use Lupron to turn off the ovary, followed by supplementation with estrogen and progesterone. Second most common way is for us to use, is to not downregulate you the month before, but when a period comes down, we can start hormone replacement, and then we have to add a GnRH antagonist in, like ganirelix acetrotide, to prevent your body from producing progesterone too early. If you produce progesterone too early before we start the progesterone, it affects the lining of the uterus and puts it out of sync. And as a result of that, the embryo is less likely to stick. The third way is to use some version of a natural cycle where we're supplementing with some estrogen and progesterone as need be, but the timing of it is totally based on what the body is doing on its own, more than us programming a whole cycle. Some people can use estrogen and progesterone without an antagonist in a cycle, but you open the door for the possibility of ovulation occurring in that scenario. It doesn't happen very commonly, but if it does, then the cycle will get canceled. And we do have to do some additional blood tests for progesterone in the middle of the cycle if we're using an estrogen progesterone replacement cycle without an antagonist being present. So those are the different variations. They all work relatively the same. Each one has some advantages and disadvantages to them. The majority of people use a program cycle, and that allows the ability to time things. It allows the ability to know who's doing your procedure. You can plan things out, and it just makes it a little calmer and so forth. But please, we try and accommodate our patients and do what's best for them and their lifestyle, as well as get things done in a timely manner from our end. Most people have no side effects from these medications. We try and provide them in as close to physiologic doses as we can, and sometimes the different formulations result in different side effects, as I mentioned earlier, and we take that into consideration as well. So please, chat with me, chat with whoever your primary physician is. You can review the different options, why we prefer one or the other, and we'll try and work with you to accommodate what your needs are, as well as to maximize our care and give you the best possible outcome. So that's the timing of it. That's how we do what we do. The other important thing is how many embryos to transfer. If they're biopsied embryos, we recommend transferring just one embryo. If you've had pre-implantation genetic testing for aneuploidy and the results are that there's a normal embryo to put back, our best recommendation is to put one back at a time. That's going to give you the healthiest pregnancy, which is usually a singleton pregnancy. We understand that in some cases there may be reasons why a couple wants to put two back at a time. It's not our best practice, but you can twist our arm for two. We won't put more than that in, and particularly if they're biopsied embryos. If they're unbiopsied embryos, then we follow the guidelines that American Society of Reproductive Medicine have set down. And again, it depends on age, quality, and past experience with embryo transfer to answer that question more appropriately on an individual basis. With biopsied embryos, the best answer is one at a time. That gives us the best results. And have a good afternoon, everybody, and I hope this was helpful. Bye-bye.